respiratory physiology. And we'll be talking about the physiology primarily, but we will also be talking about some of the clinical implications of that physiology. So our objectives are to describe the role of the brainstem and the cerebral cortex in the control of breathing, to compare central and peripheral chemoreceptors, to describe the role of the lung and other receptors, to discuss the response to oxygen and carbon dioxide, to list causes of increased and decreased respiratory drive and how we can assess that. And then we'll talk a little bit at the end about dyspnea, which is really not about control of breathing, but I think it has clinical relevance for us to talk about. I think sometimes we kind of relate control of breathing to dyspnea and so forth. We'll talk a bit more about that at the end. So this schema is an overview of the neurorespiratory system, which is involved in how we control our breathing and the response to breathing control and so forth. So shown here are the cerebral cortex first, which makes the point that we can voluntarily affect how we breathe. So we can think about our breathing and breathe more or breathe less. So we can voluntarily hyperventilate and hypoventilate and hold our breath for a while and control our breathing when we're talking and so forth. The primary controller of breathing is the brainstem, the pons and the medulla. We'll talk about that in some detail over the next slides. The brainstem then sends a signal through spinal cord motor nerves. We'll look at some of those, I think, on the next slide. And then that activates respiratory muscles to contract, either inspiratory or expiratory muscles. And then there's a lot of feedback control, including chemoreceptors and neuroreceptors. This slide reviews the major respiratory muscles, virtually all of the respiratory muscles and their innervation. So what motor nerves control those muscles? So as I'm sure you know, the diaphragm, the primary muscle of breathing, is innervated by the phrenic nerve, which arises from C3 to 5. So if there is injury to the spinal cord above the level of C3, the individual is not only quadriplegic, but is ventilator dependent for life. The intercostal muscles, whether they are the inspiratory intercostals or the expiratory intercostals, are affected by the intercostal nerves, which arise from the thoracic spine. The expiratory muscles are primarily innervated by the lumbar nerves, which arise off of the lower thoracic spine and the upper lumbar spine. So one of the points that I like to make here is if there is an injury to the lower thoracic spine, you can breathe in okay, but cannot cough effectively. So individuals who have injury at the level of like T12 to L1, T10, those individuals will be able to breathe off of the ventilator, but will not be able to cough effectively because they cannot use their expiratory muscles. So patients that have this kind of an injury may need to cough assist, but might not need any other assistance for their breathing. And then the other thing I like about this table is it also shows the innervation of upper airway muscles. So back when I was a respiratory student, many years ago, in the last century, we didn't think so much about this. But now we are increasingly thinking about the innervation of the upper airway muscles, because this has a lot to do with obstructive sleep apnea and so forth. So here again is a schema showing the central controller of breathing. So that's primarily the pons and the medulla. The sensors, chemoreceptors primarily, as well as other receptors, which send an input into the central controller in the pons and the medulla, and then the effectors, the output of the central control of breathing, are the respiratory muscles, as was shown in the innervation of those muscles on the previous slide. The central controller of breathing rests primarily in the brain stem, in the pons and the medulla. In the medulla, in the brain stem, there is a dorsal respiratory group of cells which affects inspiration, and there is a ventral group of cells which affects expiration. So in the medulla and the central controller of breathing, there are cells that control inspiration, control expiration. And then above the medulla in the pons is an apneustic center, which is in the lower pons, which is primarily for inspiration. So the apneustic center then is what controls breathing in. And the pneumotaxic center in the upper pons turns off inspiration. So in other words, if there is injury to the mid-pons, that will not affect the apneustic center. It will not affect the breathing in part, but it can affect the pneumotaxic center, which turns off inspiration. So one of the patterns of breathing that you might see in a patient with a pontine stroke, for example, is apneustic breathing, where the patient breathes. Because the lower pons is not affected, that's for inspiration, but the upper pons, which shuts off inspiration, may be affected. The cerebral cortex, the upper part of the brain, allows us to voluntarily control our breathing. So we can, as I pointed out earlier, we can breathe faster, we can breathe slower, we can hold our breath, we can vary our breathing for speech by thinking about it, which is the cortical input into the brainstem. So this illustrates the anatomy of the brainstem with the medulla and the pons. So if there is brain injury, for example, as you know, that compresses the brainstem, that affects breathing. So the apnea test that you may have done, probably have done, would suggest that the brain is so swollen that it's compressing the brain stem, which is where the respiratory control is. So if there's brain injury affecting the brain stem, as we detect in an apnea test, then likely the rest of the brain is dead as well. So this shows the medulla at the very base of the brain and the pons above it, with the pneumotaxic center and the apneustic center. So as I said, the apneustic center is the inspiratory center. The pneumotaxic center stops the inspiratory phase. So the pons then is very, the pons will determine the pattern of breathing. So the pons will be the determinant of the inspiratory-expiratory ratio as we are breathing spontaneously. So this will determine the breathing pattern, and then the medulla with the inspiratory and expiratory respiratory groups will determine how much we breathe. Breathing, there are several types of sensors that provide input into the brainstem, into the medulla primarily, and the pons. These are central and peripheral chemoreceptors, or chemoreceptors, will provide input into the brainstem. And there are also other types of receptors, as we'll see in a few minutes, that can provide input into the brainstem as well. The central chemoreceptors are found in the medulla. They are actually separate cells from the inspiratory and expiratory centers within the medulla. The central chemoreceptors are located in the medulla, and they are affected by changes in concentration within the cerebrospinal fluid. So the central chemoreceptors respond to changes within the cerebrospinal fluid. They do not respond to changes in the blood directly because of the blood-brain barrier which separates the cerebrospinal fluid from the arterial blood. And the reason why that is important is that the blood-brain barrier prevents bad things from getting from the bloodstream into the cerebral spinal fluid. So, for example, if you get a bloodstream infection, the brain tends to be protected because of the blood-brain barrier. The bacteria and other nasty things that might be in the bloodstream do not make it across the blood-brain barrier. So it turns out that carbon dioxide diffuses readily, easily from the arterial blood across the blood-brain barrier to the cerebral spinal fluid. So carbon dioxide moves across the blood-brain barrier very quickly and very easily. So changes in the PCO2 of the blood will quickly affect the PCO2 in the cerebral spinal fluid. However, other molecules within the bloodstream do not make it across the blood-brain barrier very easily. And two, of relevance to this morning's discussion, are hydrogen ions and bicarbonate ions. So hydrogen and bicarbonate tend not to move across the blood-brain barrier very readily, whereas carbon dioxide does. Changes in the arterial PCO2 then will readily affect changes in the CO2 of the cerebral spinal fluid. Changes in the CO2 or the PCO2 in the cerebral spinal fluid will affect changes in the pH within the cerebral spinal fluid. And a decrease in the pH of the cerebral spinal fluid stimulates the central chemoreceptors to increase ventilation and vice versa. So in other words, an increase in arterial PCO2 stimulates the central chemoreceptors to increase ventilation. But that is because of how the CO2 in the bloodstream affects the CO2 in the cerebral spinal fluid, which affects the pH in the cerebral spinal fluid. With chronic CO2 change, eventually the pH in the cerebral spinal fluid will return to normal, so that then, because the cerebral spinal fluid responds to changes, because the central chemoreceptors respond to changes in the pH of the cerebral spinal fluid, with a chronic increase in PCO2, the pH of the cerebral spinal fluid will eventually increase. So carbonate will eventually diffuse across the blood-brain barrier, so that then that increased drive to breathe, which initially occurred, will abate over time. So here are some diagrams to illustrate that. So here again is the brainstem, the medulla, the central chemoreceptors are located on the lateral aspects of the medulla, as is seen here. Here is the blood, specifically, I guess, arterial blood, since it's red. And here is the cerebral spinal fluid, and separating the two is the blood-brain barrier. The blood-brain barrier prevents a lot of what's in the bloodstream from readily affecting the brain. So that's a good thing as far as keeping bacteria out of the brain and infection out of the brain and so forth. But it also effectively excludes hydrogen ions, bicarbonate, and other things. Carbon dioxide, on the other hand, readily diffuses across the blood-brain barrier. So if the PCO2 in the arterial blood changes quickly, the PCO2 in the cerebral spinal fluid will change quickly. But what the central chemoreceptors really respond to is not the CO2, but when CO2 diffuses into the cerebral spinal fluid, that is hydrated to ultimately produce hydrogen ions, and it is the change in the hydrogen ion concentration, or the pH, which actually stimulates the central chemoreceptors. So the central chemoreceptors then are responsive to changes in pH of the cerebral spinal fluid, and what most readily changes the pH of the cerebral spinal fluid are changes in the PCO2 in the arterial blood. Eventually, however, even though the blood-brain barrier tends to exclude hydrogen ions and bicarbonate, eventually, slowly, they will diffuse across the blood-brain barrier. So with chronic hypoventilation or hyperventilation, there will be movement of hydrogen ions and bicarbonates across the blood-brain barrier to normalize the pH in the cerebral spinal fluid, to abate the effect of that increase or decrease in CO2 on respiratory drive. This is just illustrating the same thing in a similar way. So here's a blood vessel. So this is arterial or venous blood. And the blood-brain barrier, again, allows CO2 to diffuse and cause changes in the pH of the cerebral spinal fluid. Hydrogen and bicarbonate are, by and large, kept out of diffusing across the blood-brain barrier, and the chemoreceptors respond to changes in the pH of the cerebral spinal fluid. So this just shows the cycle of how things can happen. So if the PCO2 in the arterial blood increases, that will result in an increase in the PCO2 of the cerebral spinal fluid. That affects the hydrogen ion concentration and the pH in the cerebral spinal fluid. And the central chemoreceptors respond to that change in pH in the cerebral spinal fluid by increasing ventilation. And then that will ultimately bring down the arterial PCO2 as a result of stimulating the central chemoreceptors. So the central chemoreceptors are found in the medulla. The central chemoreceptors respond to changes in pH of the cerebral spinal fluid. And the primary factor that affects the pH in the cerebral spinal fluid is changes in the arterial PCO2. So what about the peripheral chemoreceptors? So the peripheral chemoreceptors are found in the carotid bodies, here in the neck, and the aortic bodies here in the arch of the aorta. The carotid and the aortic bodies, the peripheral chemoreceptors, are stimulated by changes in PO2, pH, or PCO2. So the central chemoreceptors respond to changes in pH of the cerebral spinal fluid. The peripheral chemoreceptors are affected by PO2, PCO2, and pH. So if there is a decrease in PO2 to a certain level, as we'll see in a minute, that will stimulate an increase in ventilation. If there is an increase in PCO2, that will stimulate an increase in ventilation. If there's a decrease in PCO2, that will stimulate a decrease in ventilation. And with a decrease in pH, with acidosis, that will stimulate an increase in ventilation. So ketoacidosis, diabetic ketoacidosis, for example, stimulates an increase in ventilation, and that increase in ventilation is mediated primarily by the peripheral chemoreceptors. So in addition to the chemoreceptors, the central and the peripheral chemoreceptors, there are other receptors found throughout the body that affect ventilation. So in the lung, for example, there are stretch receptors, sometimes called the Herring-Brewer inflation reflex, which tends to oppose inflation. So in other words, as you take in a deep breath, the Herring-Brewer reflex is sending a signal to the brainstem telling you not to breathe in so deep. And the more that you breathe in, the greater is that Herring-Brewer reflex. So the Herring-Brewer reflex then tends to guard against overinflation, which could be injurious to the lungs. There are irritant receptors found primarily in the upper airway. So those are things like noxious gases, cigarette smoke, dust, cold air. And these cause hyperpnea, increase in breathing, and they can also induce bronchoconstriction in people with reactive airways disease. So the irritant receptors can cause bronchospasm in patients with asthma and reactive airways disease, so that a person with reactive airways, when exposed to cold air, may develop bronchoconstriction, or dust or cigarette smoke and so forth. Within the lung parenchyma, there are J receptors, or juxtacapillary receptors, and the J receptors are thought to be what induces a pattern of rapid shallow breathing in patients with congestive heart failure and interstitial lung disease. So the reason then why patients with pulmonary fibrosis breathe rapid and shallow, the reason why patients with congestive heart failure breathe rapid and shallow, is primarily due to the J receptors, which are within the lung parenchyma, that get stimulated with these types of diseases. The interstitial edema with heart failure, the scarring as a result of interstitial lung disease. And then there are a number of other nose and upper airway receptors. Many of these have not been studied very well. And there are receptors within the joints and the muscles, and baroreceptors, and pain and temperature receptors, which also can affect the pattern of breathing. So, for example, how do you usually breathe if you have pain? You breathe faster. So that's probably due to one of these receptors. Why do you breathe faster if you have a fever? Well, part of it is so that you don't increase your PCO2. But part of it is because of temperature receptors. Why do you breathe more when you exercise, if you exercise? So this hasn't been a problem for me, but, but why you breathe more with exercise is related in part to receptors that are found in joints and muscles. So the reason for the increase in ventilation with exercise is not just because you're producing more CO2, you need to breathe more to get rid of that. And in fact, with exercise, many people hyperventilate. They overventilate, and it may be related to receptors in the joints and muscles. So there's really a lot that goes into controlling how we breathe. Now let's talk a little bit about the specific responses to changes in carbon dioxide in the bloodstream and changes to oxygen within the bloodstream. So here you can see in this figure, this is data from many, many years ago, done on primarily normal volunteers. So here we can see ventilation as a function of alveolar PCO2, so this is to represent arterial PCO2. And you can see as the PCO2 increases, ventilation increases. There's nothing new about that. And shown here is the slope of the relationship between ventilation and PCO2. And you can also see here, you only need to increase the PCO2 a little bit in order to increase the ventilation a lot. So normally, you get an increase in ventilation of about 3 liters per minute for every 1 millimeter of change in the arterial PCO2. So increasing, so what does that mean? If your PCO2 goes from 40 to 45, that means you would increase your ventilation by 15 liters per minute, which is like 4 times what is your resting ventilation. Wow. I can tell you, and Bob will remember this, 25 years ago when we were doing CO2 rebreathing studies for some of our PAV work and so forth, when the lab was on the other side of the wall here, being involved in some of those studies, for me, if my PCO2 went, my end-tidal PCO2 went from 40 to 44, I was just breathing as hard as I could. I just couldn't breathe anymore. So CO2 is a very strong drive to breathe. Only a small increase in PCO2 results in a big increase in ventilation. A decrease in PCO2, on the other extreme, below normal, decreases the drive to breathe. And the apneic threshold is only about 3 or 4 millimeters of mercury below the resting PCO2. So what that means is that if you ventilated me, if my PCO2 is 40, you ventilated me down to a PCO2 of 35, I would have a period of apnea while my PCO2 comes up over 40 to stimulate me to breathe again. So I have had the experience more than once over the last almost 50 years now, if you can believe, where you initiate a spontaneous breathing trial and the patient doesn't start breathing. But if you just watch them for another minute, all of a sudden they start breathing. And why is that? Well, that's because that patient has been ventilated below their apneic threshold. So you need to wait for their PCO2 to come up in order for them to begin breathing again. I don't recommend that you walk away and see another patient while you're waiting for them to their PCO2 to come up above their apneic threshold, but I think that occurs probably not uncommonly. Probably occurs a lot less now with pressure support than it did 40 years ago before pressure support. The CO2 response is also affected by the PO2. So here's a PO2 of 100, a PO2 of 47, a PO2 of 37, and you can see that the slope of the relationship increases as you become more hypoxemic. So normally, this is the relationship between PCO2 and ventilation. But if I make you hypoxic first and then do the same study, you're going to breathe even a lot faster, which I think stands to reason. CO2 response is reduced during sleep. So all of us have a couple of millimeter of mercury increase in our PCO2 at night. If you don't believe that, we could probably test that. Just let us know when you're taking your next nap and we'll figure out a way to test that you may or may not like. CO2, and then we could also test the response to pain, right? The ventilatory response to pain at the same time. CO2 response is reduced with opioids, propofol and barbiturate. That's sometimes the reason why they're used in mechanically ventilated patients is not only for pain control, but also to suppress respiratory drive if the patient is very asynchronous, for example. And then one of the newer drugs, which I think is used increasingly, dexmedetomidine, which I hope I spelled that correctly, which is Precedex, provides sedation without respiratory depression. So a big advantage over Precedex as compared to opioids or propofol or barbiturates is that you don't get the respiratory depression with Precedex as you get with other agents. And then the other thing is that there is a lot, very much intra-individual variability in respiratory drive. So the question that is raised sometimes is you have two patients with pretty much identical degrees of COPD, of injury due to COPD, and one patient has a PCO2 of 60 and the other patient has a PO2 of 40. And the big question is, well, why does one patient with COPD who has an FEV1 of 40% predicted, why do they let their PCO2 go up to 60 to reduce their work of breathing, and the other patient breathes harder, increases their work of breathing to defend their PCO2? And the answer might just be that there's a lot of variability among individuals as far as response to PCO2. I think I'm one of those persons who has a very sharp response to CO2. So if I develop COPD, which I don't have any plans on doing, I would probably be a pink puffer rather than a blue bloater, because I know, because I was involved in studies where we have tested this, I don't tolerate an increase in PCO2 very well. So what about the response to oxygen M? So let's look at this curve primarily at first. So this is ventilation as a result of alveolar PO2, or we'll call this arterial PO2 for sake of argument this morning. And this is with a relatively normal PCO2. We'll say this is a normal PCO2. So you can see that the increase in ventilation really doesn't kick in until the PO2 drops below about 60. So the response to oxygen is that when the arterial PO2 drops below about 60 millimeters of mercury, then further reductions in arterial PO2 will increase the response to ventilation. So that's what we call the hypoxic drive. So you and I really aren't breathing because of the level of oxygen in our bloodstream. I assume that all of us have a PO2 of 80 to 100. So we're not breathing so much to control the oxygen in our bloodstream as we are to control the carbon dioxide in our bloodstream. Because the hypoxic drive really doesn't kick in until we get down to around a PO2 of 60. This is also affected by PCO2, so you can see that that changes as the PCO2 increases. So respiratory drive is greater with hypercapnia and hypoxia than it is with hypoxia alone, which I think that stands to reason. So then clinically, there are a lot of factors that can affect our respiratory drive. So things that can increase respiratory drive are, first of all, hypercapnia. That is probably the strongest drive to breathe, driving up our drive to breathe. And this is the result of both the central chemoreceptors and the peripheral chemoreceptors. Acidosis increases the drive to breathe, primarily through the peripheral chemoreceptors. So in an individual with ketoacidosis or lactic acidosis, that there will be an increase in minute ventilation, which will tend to try to correct the pH, but it is the acidosis that is driving breathing. With hypoxemia, there can be an increased drive to breathe, but that only occurs once your PO2 drops below about 60 millimeters of mercury. So if you hike to the top of Pikes Peak, for example, I don't know if anybody's ever done that, or if you've gone to the Rocky Mountains and you've hiked to the top of any of the mountains, you breathe more. And the reason why you breathe more is because your PO2 drops down into the 50s. So even for me, going to Denver or Salt Lake City, I can sense an increase in ventilation as a result of my PO2 probably being in the 50s. Pain affects respiratory drive. So with pain, there is an increase in ventilation. Anxiety increases ventilation. So you have probably sensed already when a friend or a family member is very anxious because of how it affects their breathing. There are drugs that increase respiratory drive, such as aspirin. So someone with an aspirin overdose tends to hyperventilate. Xanthines, theophylline, this would be, increases respiratory drive. There was a time in my career when theophylline was fashionable to administer to patients to increase their respiratory drive. And I don't think that that's consistent with current thinking anymore. I don't know, do they still do it in babies? Patty, you're back there kind of shaking.
We do caffeine mostly.
Caffeine, yeah. That's right, I should have caffeine on my list because caffeine is a first cousin to theophylline. So. Yeah, so think about that the next time you have your 20-ounce Starbucks latte. That's a good point. I should add, for the next time I do this talk, if I ever do it again, which I may, put caffeine on the list. That's a good point.
That's why recently, I've had some patients, not recently, but in the past like 4 years, they started, COPD patients come in, they were on theophylline on them.
To increase their respiratory drive?
Yeah, I think that's why.
Because it's also a bronchodilator. So in less...
I thought they weren't using it much anymore.
Yeah, I mean just a few years back. I'm sorry, a few orders.
So in developed countries, if we can call ourselves one, theophylline's almost never used. But in poorer countries around the world, theophylline's used a lot as a bronchodilator because they can't afford all of the expensive bronchodilators that we use here. Progesterone is a respiratory stimulant. I can recall in the past when progesterone was administered to patients as a respiratory stimulant. I don't think that's done anymore. But an implication of that is that women who are pregnant hyperventilate. So if you do a blood gas on a pregnant woman, and I would not recommend that you do that unless she also has respiratory failure, you'll find that the PCO2 is almost always in the low to mid 30s. And I can recall back early in my career being called to draw a blood gas on a woman who was pregnant, who also had asthma. As it turned out, her asthma wasn't a big deal, but they wanted a blood gas because we did a lot of unnecessary blood gases back in those days. And I was surprised about why her PCO2 was 30 and everything else was normal. I mean, and I thought that it must have been my technique.
It hurts.
But I also noticed that her pH was 7.4. So why would she have a compensated respiratory alkalosis if this was just due to she didn't like me sticking the needle in her arm? Because then her PCO2 would have been 30, her pH would have been 7.48 or something like that. So that caused me to go and look it up, and lo and behold, that's when I learned that progesterone is a respiratory stimulant, and there's an increase in progesterone in pregnant women, part of the pregnancy, changes in hormones and so forth, and progesterone causes, the result of that is the pregnant women hyperventilate. And then doxapram, which is an old drug. I don't even know if you can get it anymore, but back in the early days of my career, this was used sometimes as a respiratory stimulant, primarily in the post-anesthesia patients. So post-op patients, years ago, used to almost routinely get doxapram as a respiratory stimulant. Remember that, Bob, back in the 70s and 80s? Everybody, every patient after surgery got doxapram as a respiratory stimulant. And then something that can decrease respiratory drive is obstructive lung disease, such as with COPD, because as we pointed out, with chronic hypercapnia, eventually bicarbonate will diffuse into the cerebrospinal fluid in order to bring back to normal the pH of the cerebrospinal fluid. Things that can decrease respiratory drive are hypocapnia, hyperventilation, so ventilating to below the apneic threshold, as we had mentioned. Alkalosis, although alkalosis is not a very strong depressant of respiratory drive. So patients will tend to defend their PCO2 more than they will defend their pH. So it's very unusual that a patient with a respiratory alkalosis will hypoventilate to compensate for the metabolic alkalosis. Did I say that wrong? I might have said that wrong. So let me start again. Hopefully I have it come out right this time. So a patient with metabolic alkalosis usually will not hypoventilate in order to correct the metabolic alkalosis, because CO2 is a greater drive to breathe than alkalosis. So there will be a tendency to protect the PCO2 rather than the pH. Did I get it right this time?
Yep.
There are a number of drugs that will depress respiratory drive: narcotics, opioids, propofol, barbiturates. And then I think I'd already pointed out that respiratory drive tends to be decreased a bit during sleep. So all of us normally have a couple of millimeter of mercury increase in our PCO2 while asleep. So shown on this slide are a number of different respiratory patterns, and I won't talk about all of them this morning, but I did want to say a word about a few of them. So bradypnea, a slower than normal respiratory rate, is almost always the result of respiratory depressants, usually the result of opioids. So bradypnea is a cardinal sign of narcotic drug overdose. So this is where the paramedics would use Narcan, for example. But Cheyne-Stokes breathing, and everybody knows what Cheyne-Stokes is, right? That's not a surprise, mystery to anybody. So it's varying periods of increase and decreasing rate and depth of breathing. The important thing about Cheyne-Stokes breathing, I think, is that it is not affected by breathing. It's not affected by the lungs and respiratory failure. So Cheyne-Stokes breathing is not a problem with the lungs. If a patient has Cheyne-Stokes breathing, it is almost always due to heart failure or due to stroke. So patients who have chronic congestive heart failure might have Cheyne-Stokes breathing with periods of apnea, so varying rate and depth of breathing with periods of apnea. Patients with stroke may have Cheyne-Stokes breathing. That's not an indication to put the patient on a ventilator or to trach the patient in and of itself. And it's also not a reason to extubate a patient who's on a ventilator. So just because the patient has Cheyne-Stokes breathing doesn't mean that they necessarily need to be on the ventilator unless they also have respiratory failure. So Cheyne-Stokes breathing is about cardiovascular disease. It's not about respiratory disease per se. Kussmaul breathing, breathing as fast and as hard as you can, as deep as you can, is usually the result of diabetic ketoacidosis. So patients who come into the emergency department with uncontrolled diabetes may be breathing with tidal volumes of 2 liters at 30 times a minute due to the ketoacidosis, the acidosis stimulating the central or peripheral chemoreceptors. I'm not going to call on Amy because I said I wouldn't call on her just because she's sitting up here. So is this stimulation of the central or peripheral chemoreceptors? Pardon? Peripheral chemoreceptors. Central chemoreceptors respond to changes in the pH of the cerebral spinal fluid, which is due to changes in PCO2 of the arterial blood, not pH. And then the other thing I wanted to point out that tachypnea, there's actually a lot of literature about this, and for another project that I was involved in, looked at this not too long ago. There's a lot of literature that suggests that tachypnea is associated with poor outcomes. And in patients in the general wards of the hospital who are developing respiratory compromise, for whatever reason, post-op or whatever reason, tachypnea is one of the very first clinical signs that occurs in those patients. So you would think then that we would pay a lot more attention to respiratory rate in patients out in the general ward, and it is, unfortunately, it's not paid much attention to at all, and it's usually not assessed very carefully. It's kind of an afterthought, and there is some thought among some that maybe we need to use respiratory rate monitors more out on the general wards of the hospital to detect tachypnea early as a sign of impending respiratory compromise. And you may or may not know this, I thought about this on the train on the way here this morning. I should have put in some slides about ways that we can monitor respiratory rate, because there are a number of new non-invasive techniques to do that. And one of them is pulse oximetry. So there are now pulse oximeters that, by looking at changes in the plethysmographic waveform, can very accurately determine respiratory rate. So there are now pulse oximeters, for an extra cost, of course, that will give you not only oxygen saturation and heart rate, but also give you respiratory rate and pattern. So, so sort of stay tuned to all of that, because there is, as it turns out, like I said, there is some pretty robust evidence to show that tachypnea is one of the first things that happens in patients that have bad outcomes in general hospital wards. And if you go out and you look at the, not to pick on anybody who measures respiratory rate, but if you go out and you monitor respiratory rates that are recorded in the medical record, the average is 20, because lots of times people
Yeah,
just
18.
chart 18 or 20 or 22 and not really measure it very carefully. So then, how can we, I always wonder if I have enough material, and I always look up at the clock and I say, oh, 10 minutes and 50 more slides. Not quite. So then how can we assess respiratory drive? Well, one way we can assess respiratory drive is to administer inhaled carbon dioxide and see how much the bed of ventilation changes. So then for an individual to construct one of those ventilation versus PCO2 charts. So that's one way that it can be done. The other way, and more common way it's done, is by measuring occlusion pressure. And as you know, that's something we can measure on most modern ventilators have the ability to do that. And we'll talk about what that means in a minute. The first thing that's important to appreciate is that both of these tests assume that the patient's neuromuscular apparatus is working. So the patient does not have motor neuron disease, the patient does not have a myopathy. So in a patient with ALS, for example, they're not going to have a very good response to CO2. And it's not because of their brainstem, it's because of their motor neurons. Or in a patient with any of the muscular dystrophies, you give them CO2 to breathe, they're going to have a strong response in their brainstem. It's not going to feel very good, but they're not going to increase their ventilation. So the occlusion pressure, which sometimes we call the P.1 or sometimes we call the P100, is the pressure generated 100 milliseconds after the onset of inspiration against an occluded airway. And this is generally thought to be effort independent, because if your airway is occluded right at the beginning of inspiration, it takes more than 100 milliseconds for you to recognize that your airway is occluded and try to breathe in harder as a result of that. It reflects both drive and strength. This gets back to the previous slide. So the patient has motor neuron disease or weak respiratory muscles. It may reflect strength more than drive. A normal value for you or me is about -1 to -2 centimeters of water. With 0 to -2 reflects a weak drive or respiratory muscle weakness. If it is less than -4, which is -5, -6, -7, -8, there's either, that reflects an increased respiratory drive, and that also reflects an increase in work of breathing, because if you're breathing more, that increases your work of breathing if you have an increase in drive. The reproducibility is really not very good. It's suggested by some to make 2 or 3 measurements and average them in order to get a reading that may be a bit more valid. Now, it turns out that, as I said, we cannot adjust our inspiratory effort to an increased load within 100 milliseconds of inspiration. So, as I said on the previous slide, if I come up behind you and I occlude your airway right at the beginning of inspiration, it takes at least 100 milliseconds for your brainstem to recognize that, and then you try to breathe in harder. So that means that a trigger delay on the ventilator of less than 100 milliseconds will be imperceptible to the patient. That doesn't mean that it's okay, but it means that the patient's not going to detect that as an increase, a need to increase their respiratory drive. In non-intubated patients, like in the pulmonary function lab, this can be measured using a valve that randomly closes at end exhalation and then opens after 100 milliseconds. At the beginning of inspiration, there are commercially available systems to do this, so the patient's breathing in and out through a mouthpiece. And then it's done randomly, so the patient doesn't know it's going to happen on the next breath. The valve closes when the patient begins to breathe in, and then it opens almost immediately, like in 1/10 of a second. And this can be measured or calculated on the ventilator because the inspiratory valve does not open immediately in response to patient effort. So there's a lag between patient's effort, the inspiratory valve opening. That can be used to determine the P100. So this is from a study that was done, oh golly, almost more than 20 years ago now, almost 25 years ago, looking at P100 as a function of work of breathing. And you can see at the normal range for P100, -2 to -4, as I pointed out in a previous slide, that translates into a work of breathing of about 0.5 to 1 joule per liter. So this turns out to be the normal range for work of breathing. So the normal range for P100 corresponds to the normal range for work of breathing. And you can also see that if your P100 is -6 or -8, then there is an increase in work of breathing. The other thing that has been shown in this study and in others is that patients who fail their spontaneous breathing trial tend to have an increase in P100. So you can see in this series of patients, as the level of pressure support is decreased, the P100 increases, respiratory drive, work of breathing increases, and in the patients who fail, there tends to be a higher P100, or I shouldn't say higher, more negative is probably, probably the best way to say this is a more negative P100 in the patients who failed their spontaneous breathing trial.
So can I just ask you on the side of that?
Sure.
Is that -1, 2, 3, 4, 5?
So this should really be, you are correct, this should be -1, 2, 3, 4, 5. Yeah. So I took so for my next time I do this talk, thanks to Patty, I will correct these authors' data. Yeah, so this should be -1, -2. Yeah, I only recognized that myself when I corrected partway through the slide that they were, what'd you say, Bob?
Is it a bad journal editor?
Yeah, right. This was not published in Respiratory Care. So then there's been interest in looking at P100 in mechanically ventilated patients. So P100 or P.1 of 0 to -2 represents weakness or paralysis or too much support on the ventilator. So maybe there's so much support on the ventilator that the PCO2 is below the apneic threshold. -2 to -3 is thought to be an adequate level of ventilator support. -4 to -5 would suggest an increased level of support. And P100 of less than -5, -6, -7, -8 represents there's an increased level of support is needed, and this is wrong here, this should be increased drive, right? Yeah. Ooh. So I take full responsibility for that one. So on your handout, cross out decrease and say increase. So this should be an increased level of support needed or an increased drive. Would that correct it?
That's correct.
So then, so your patient is on a pressure support of 10, and their P100 is -6. So what might be a reasonable response to that?
Increase the
Pardon?
pressure.
Increase the pressure support. I told Amy I wouldn't pick on her because she sat up here and she volunteered the correct answer anyway. Again, an average of several values rather than an isolated value is probably better, and the response to a change is probably more important than an isolated change. So what you would want to see is on that patient with a pressure support of 10 and a P100 of -6, you increase the pressure support to 15, and now it's -5, and then you increase it to 20, and now it's -3.
The only caveat I'd make to that is there are other things other than decreased ventilation, as Dean said, that will stimulate ventilatory drive. So if the
Correct.
patient hypoxemic, febrile, are they in pain? All
Correct.
the other things that he has mentioned to always consider in addition.
Right, so that's an excellent point, because if the pressure support was 10 and the P100 is -6, and then I go up to 25 on the pressure support and it's still -6, then that would suggest that it's pain, anxiety, fever, something else which is affecting the respiratory drive. So I've used up my time. I can always continue.
So let's
but
finish this topic here, though.
Okay, we'll finish this and then we can talk about dyspnea another time. And maybe I'll just make one point about dyspnea, and then we can talk about it in more detail another time. So is hypoxic drive important in COPD? Well, interestingly, maybe not as much as was once thought. So it was shown in this study done way long time ago, back in 1980, that in patients with COPD, when they gave them oxygen, their PCO2 did increase by a small amount, 60 to 68 millimeters of mercury. There was a decrease in their minute ventilation, a little bit, not very much, like 14%. So was that due to giving them oxygen and shutting off their hypoxic drive? The answer is no. Because when they looked at respiratory drive, P100, P.1, the respiratory drive decreased when they gave them oxygen from -8 to -5, but this is still more negative than the normal value. So these patients' respiratory drive was affected a little bit by giving them oxygen, but it did not shut off their drive to breathe. So you cannot attribute this increase in PCO2 and this decrease in ventilation to shutting off the hypoxic drive, because the respiratory drive was still greater than normal after they gave them oxygen. So then the whole business about we give oxygen to a patient with COPD, they'll stop breathing, is nonsense. It's not based upon physiology or evidence. And in fact, if you measure the respiratory drive in patients with COPD, after you give them oxygen, their respiratory drive is still greater than normal. So then, why does their PCO2 go up? And this is likely the result. It is the result of the Haldane effect, which is the relationship between carbon dioxide concentration in the blood, PCO2, and oxygen saturation. So this is the CO2 dissociation curve. And here it is, if there is no oxygen in the blood, if the oxygen saturation is 75%, if the oxygen saturation is 98%. So here is the case. Let's say your patient comes in with COPD and they are hypoxic and their oxygen saturation is 75%. It's not uncommon, right? And we would give that patient oxygen. I would hope to get their saturation up to about 90. So in that case, the CO2 concentration in the blood is 60 milliliters per 100 milliliters of blood, and the PCO2 is 60. Now, if we increase the oxygen saturation up to 98%, higher than I would suggest that we should do for a patient with COPD, now we go from this curve to this curve. The amount of carbon dioxide in the blood doesn't change, because we're not changing ventilation. But by increasing the amount of oxygen on the hemoglobin, it pushes carbon dioxide off of the hemoglobin. So carbon dioxide comes off of the hemoglobin, it's still dissolved in the bloodstream, which drives up the PCO2. So in this case, from 60 up to 65 or 70 millimeters of mercury. But it is not because of a change in respiratory drive. It is because of a change in how the carbon dioxide is carried in the blood, because with a higher oxygen saturation, it pushes carbon dioxide off of the hemoglobin, and it's only the carbon dioxide which is not bound to hemoglobin that we measure as PCO2.
So sometimes we could probably get a false negative sometimes if we throw someone on BiPAP and GD or something like that. And a little bit, right? Like you can throw them on, if you give them a little bit too high of FiO2 and they come back, oh, the gas is a little worse. Could be a little bit of that.
Yeah. And I don't debate that we give them oxygen, their PCO2 will go up. But it's not because we gave them oxygen and it shut off their hypoxic drive.
But I think the important thing is what Dean said, the amount of CO2 in the blood has not changed.
Exactly, it just goes
It's
to
just the
bicarbonate.
distribution of that
Correct.
CO2
Right.
has changed. But this is almost like religion.
Yeah, that's what I mean, because the
People
doctor
believe
will
that
come
there
to
is
me
an
and say,
hypoxic drive, and it depresses respiration, and it's very difficult to get somebody who's had that attitude for 20 or 30 years
yeah.
to change their perspective on it.
So it's not
It
the
could be
result
dangerous.
that's in debate.
Of course it can be
It's the
dangerous.
mechanism that's in debate.
Okay.
So you give them
Withhold.
oxygen, their PCO2 goes up.
Yeah.
And you can blow off more CO2 by how you set the non-invasive ventilation for the patient. But their PCO2 went up primarily because of this effect, the Haldane effect, not because the oxygen shut off the drive to breathe.
right,
But Dean's other comment was really appropriate. I mean, with the COPD patients, you don't want to push their PO2 up to, 95. You want to get it into the 60, 70 range, because that's what they're used to living at, and not, overdo it.
Yeah, if you drew another curve between the 75 and the 98 for an oxygen saturation of 90, you could see that then the effect is not as great.
Is much more reduced. So it really depends on the response you get to the oxygen therapy and how much you're using. Obviously, you should use enough to correct the hypoxemia, but not enough to induce a significant change in the CO2.
right.
Yeah, and there is a plethora of literature now on patients with COPD as well as critically ill patients that driving off the high saturations leads to poor outcomes for a lot of different reasons.
Any other questions or comments for Dean?
Just had like a couple more. So you had that progesterone, right?
Yeah.
So the baby's in the womb, and it seems to make sense, but I just want to make sure I'm thinking right. So the baby's producing more CO2, so mom's got to blow up hers and the baby's, right? So that's why the progesterone.
Yeah, but the baby's not making very much.
Yeah, okay.
So
But it's
because
because
the amount of carbon dioxide is dependent upon the amount of metabolizing cells. So yeah, so that's you're correct. I mean, there will be some increase in ventilation because the baby's making a little bit of CO2, but not very much. There's also some increase in ventilation because because of the effect on work of breathing and the increase in CO2 production, and then the progesterone effect.
And then for the blood-brain barrier, like if you get like bacterial meningitis, so I know like you'll get a temperature, so you'll have like you'll be breathing faster.
Yeah, so patients with meningitis are tachypnic, right?
Right.
Yeah.
But how does that affect the?
Yeah, so there the problem is that the bacteria have not been kept out of the cerebral spinal fluid, right? That is meningitis by definition, right?
Right.
So there the system has failed. The other thing that I thought about saying that came to my mind as I was going through the blood-brain barrier stuff, and I did not, but I'll try to develop now. We can do this as a group. So think about the patient who has a cardiac arrest, and they are acidotic for a while, and as a result of their bloodstream acidosis, they will, over some time, they will also develop a CSF acidosis. And also because the brain itself, being hypoxic, is producing acid, so the CSF is very acid. So that'll stimulate an increased drive to breathe. So now you successfully resuscitate the patient, and they are given some buffer, and they are no longer making lactic acid. And now, a day later, the patient continues to hyperventilate. How can you explain that? So now it's a day later or a day and a half later, and now the patient's PCO2 is 25, and their pH is 7.55.
Well, yeah, that doesn't measure the pH in the CSF.
Correct.
Right.
The CSF may still be acidotic because of that,
Yeah, so
that increase in hydrogen ion concentration that occurred during the cardiac arrest, which might have been a lot due to hypoxia of the brain, takes a while to diffuse back across the blood-brain barrier into the bloodstream, where it can be cleared.
Right, it may take more than 24 hours.
Correct. And it may take more than 24
And one
hours.
thing, and I promise I'm done, but,
Take as long as you want. I'm just impressed that you
Did you
didn't
save
stage
these
now,
up
you
for
know.
huh?
Did you save these
No, I
questions?
just, they just propped up in the old noggin here when I was So I guess like in the ED, like when I see people like very tachypnic, I start to get a lot more scared now. Like
Should.
So yeah. So
You should.
Well, obviously for obvious reasons, but hearing this like that has worse outcomes. I mean, it's obvious, but sometimes like you get.
And it's
something
not
to do-
because the tachypnea itself is bad, but it's a symptom of badness.
Yeah, that's what I mean. So sometimes I get people in and like I don't know why they're tachypnic. I just had a guy this morning.
But it
and he's
needs to
on-
be worked up.
Of
Yeah,
course.
Yeah.
Yeah. So I'm like.
Maybe it's early sepsis.
Yeah.
That would be really bad, right?
And sometimes it's a mystery though. Sometimes it can be viral or PE.
Yeah.
Like sometimes you're just like, what is this? But you
But
put
now-
someone. I put someone on, or someone last night put someone on high flow and then BiPAP, and then they're still like tachypnic, and they're alkalotic and the ABGs and stuff like that.
But now for that tachypnic patient, you got a lot of things to think about.
Yeah, of course.
Yeah.
But it's just something I've been paying attention to.
Yeah.
Like I can't resolve it, and it's just like, oh,
Yeah,
this guy,
so
like, sick.
so tachypnea, the importance of tachypnea, I think, has traditionally been ignored, and I think it's mostly been ignored because we haven't paid very close attention to it.
Yeah, it's like usually we could fix it, right?
Yeah.
And they're like, oh, okay, cool, but like sometimes you just can't fix it and everything else, and that's when I start to worry.
Yep.
Can I just ask, we have a patient upstairs and she's somebody she's had, so she's coming, she's septic right now, urosepsis, but she's neurologically, she's acting, she's